Good morning and good afternoon, everyone. My name is Tamil Kendall, and I am the director of the Partnership for Women's Health Research Canada, a national alliance of women's health research institutes that includes the Women's Health Research Institute at BC Women's Hospital, the Women and Children's Health Research Institute in Alberta, Women's College Research Institute at Women's College Hospital in Toronto, IWK Health, and the Women's Health Research Cluster. To begin, I would like to respectfully acknowledge that at my location in Vancouver, I am on the traditional unceded territories of the Musqueam, Tsleil-Waututh, and Squamish First Nations, and to express my gratitude for being here today. Since we are joining from across the country, I would invite you to take a moment to think about and acknowledge the traditional territory that you are joining from. I would also really encourage all of you throughout the presentation to share your thoughts, comments, and questions in the chat. It gives me great pleasure to welcome you and our stellar panelists to the first of our Partnership for Women's Health Research Canada research seminars. The theme of the 2022-2023 seminar series is knowledge mobilization to benefit the health of women, trans, and non-binary people. We are beginning with a deep dive into a topic that is very close to my heart, working with communities to design and implement women's health research, recommendations on how to do it well, challenges and lessons learned for knowledge mobilization. What will happen today is, to begin, we will have some remarks from Alison Borgon, the Director General of Science Policy at the Canadian Institutes of Health Research, on CIHR's new strategic plan and the place of knowledge mobilization within it. We will then turn to a presentation from Richard Oster and Denise Young on their work with the Musquatchees community in Alberta, and then to Laurie Smith and Dr. Carolyn Nagasige about national and global work on self-screening for cervical cancer prevention. So again, welcome everyone. Please share your thoughts in the chat, and I'm going to turn it over to Alison. Alison, the floor is yours.
Wonderful. Thank you so much, Tamil, for the warm welcome. I would like to start that by acknowledging that I am joining you today from the traditional and unceded territories of the Anishinaabe Algonquin Nation, and that I am so pleased to have the opportunity to be engaging with all of you today. And I will be starting off the session with just a quick overview of some updates from CIHR, and then passing along to a stellar panel of individuals who'll be sharing their knowledge and expertise. So if you'll bear with me for just 1 minute, I'm going to get my slides up and running. Wonderful. So as mentioned, I'm just going to be providing a short high-level overview of knowledge mobilization at CIHR. So as many of you may be aware, in early 2021, CIHR did release a new strategic plan. That's a 10-year plan. And this was informed by a large public consultation. And resulting from this, we did design a strategic plan that's purposely impact-oriented with a strong commitment to integrate evidence in health decisions, including by advancing the science of knowledge mobilization, as well as maximizing results for Canadians. And this was done as we heard very clearly that the community was looking for us to kind of bring back and re-enhance our focus on knowledge mobilization. So the vision for knowledge, the knowledge mobilization priority at CHR is that in 10 years, research evidence will be integrated seamlessly within Canadian health policy and practice. And this vision is paired with a very strong equity lens throughout the strategic plan, including commitments to address anti-racism and systemic ableism in the funding system, to reduce health inequities through research, and to remove barriers to Indigenous-led research and to improve the health and well-being of Indigenous peoples. With the new strategic plan, as some of you may have noticed, CHR is switching our terminology from knowledge translation towards the use of knowledge mobilization. And I thought I'd just speak to the drive behind this change, which is to modernize our approach to reflect the need for a broader, more action-oriented, inclusive, and equitable approach to evidence uptake. And to note that within the knowledge mobilization messaging that we will have going forward, we are aiming to support the appropriate mobilization of different types of knowledge, including Indigenous sources of knowledge, to encourage the use of inclusive knowledge mobilization methods, and to value equitable and sustainable partnerships between researchers, knowledge users, and knowledge holders. So to implement our knowledge mobilization commitment, we are developing a new knowledge mobilization framework and action plan. And this framework will provide opportunities for both CHR and the research community to enhance knowledge mobilization practice, including collaboration with patients, communities, and individuals with lived and living experience. And it will also support knowledge mobilization science, or the study of knowledge mobilization practices, in order to advance and optimize knowledge mobilization approaches. And this does include support for implementation science, which I appreciate some colleagues will be speaking to today. So when we were informing the first iteration of our knowledge mobilization framework and action plan, we did look to literature, to national and international best practices, as well as we held a number of small group engagements where we heard from researchers, policymakers, patients, community members, and received very insightful feedback. And through this engagement, in relation specifically to research and knowledge mobilization with communities, these engagements really confirmed the importance of CHR increasing incentives for co-produced research, such as through dedicated funding streams for research with knowledge users and keepers. The importance of providing support for fostering networks, developing skills, and having protected time to meaningfully engage patients, communities, and individuals with lived and living experience. And also that we needed to better consider equity, diversity, and inclusion, Indigenous rights, and intersectionality when designing and implementing our new knowledge mobilization interventions, including ensuring that we're broadening our consideration as to what knowledge should be mobilized, by whom, how, and with what aims. So I'm now going to turn to a snapshot of knowledge mobilization interventions at CHR with a focus on women's health. The first that I thought to highlight is that as a federal agency, we do actually engage in knowledge mobilization practice ourselves by acting as a knowledge broker to bring relevant evidence to policy partners and making connections between academia and government. And one example is through our Best Brains Exchange program, where we bring together evidence to inform policy partners in areas such as breast cancer screening and health inequities among sexual and gender minorities in Canada. And increasingly, we are trying to bring in the patient and community voice into these dialogues. The next piece I thought to highlight is that as our role as the federal health funder, we do invest in women's health research and knowledge mobilization with communities through strategic initiatives, as well as through our institutes, most notably our Institute on Gender and Health. And today I'm going to highlight just two recent or ongoing initiatives that I hope will be of interest. The first is one that was released earlier this year, which is called Women Rise. And it was launched to support action-oriented and gender transformative research with a focus specific to how women's health and work intersect in the context of the COVID-19 pandemic. And bringing in the knowledge mobilization lens, these projects are intended to inform post-pandemic recovery, and therefore teams are required to have strong community engagement strategies that will include how evidence will be shared and its potential to have meaningful impact. The next initiative that I'd like to highlight today is one called the National Women's Health Research Initiative, which hopefully is familiar to some of you. And this initiative is intended to advance a coordinated research program to produce evidence that will improve healthcare and outcomes for women and gender diverse people. It's envisioned that this initiative will help transform women's health research and practice by using a community-based approach aligned with commitments to principles of equity, diversity, inclusion, and Indigenous rights. And within this initiative, I did want to highlight the first funding opportunity that's coming out, which is for a Pan-Canadian Women's Health Coalition. And again, with that knowledge mobilization lens, this coalition will engage in community-based priority setting, as well as mobilize and scale both existing and new knowledge emerging from Pan-Canadian hubs. So with that, I would like to thank you for the opportunity to join with you today, and also to learn as well as I look forward to listening to the following presentations. It's now my pleasure to welcome our panelists, and we will be starting with presentations. Let me stop sharing, by Dr. Richard Oster, who is the Scientific Director of the Indigenous Wellness Core of Alberta Health Services and an adjunct assistant professor at both the University of Alberta and the University of Calgary, as well as Denise Young, who is a research assistant with the Indigenous Healthy Life Trajectories Initiative of the Maskwacis Maternal, Child, and Family Wellbeing Research Group. So with that, it's my pleasure to pass it over to Richard and Denise.
Thank you so much. I'm just going to share my screen. I trust everybody can see that. So good morning, everyone, and I guess good afternoon to some of you. Thanks so much for that introduction, and thanks for the invitation to Denise and I. We're both really happy to be here. So as was said, my name is Richard Oster. My spiritual ceremonial name is Wapastem, which means white horse in Cree. I come from mixed European descent. The biggest piece of me, I guess, would be Danish ancestry. But since birth, I've called Treaty 6 territory and Métis Region 4 here in Alberta my home. So I live in Edmonton. That's where I'm calling in from today. My family's lived in this part of the world for 4 generations, and this is where I continue to live and raise my 2 teenagers. I've been really privileged over the years and lucky, I think, to be able to partner with a number of Indigenous communities here in Alberta, including the Cree nations of Maskwacis, where I've been partnering for over 10 years now. I usually like to say at the start of these sorts of things that I'm not an expert. I don't try to be one. I'm just a partner working together to build from the strengths, the many strengths that exist within the communities I'm partnering with. And ultimately, we hope that that will improve well-being for community members. That's our goal. And that's the positionality I work from within my role as scientific director at AHS and also my adjunct positions. And I'm here today with my friend and colleague, Denise Young, who works with me in Maskwacis. She'll have a chance in a few minutes to introduce herself when I turn things over to her. Our plan in the very short amount of time we have with you is to give a very, very brief overview of our research partnership that we've developed in Maskwacis and talk a little bit about our processes of community engagement and relationship building and how we work together, how we try to work together in an equitable way, and perhaps a few of the examples of what we think can ensue from this type of approach. So with that, in the interest of time, I'll jump right into things. So our partnership, we've been working together for over 10 years now. The partnership has, over that span, has primarily included elders from the community, community members, moms and dads, program managers that work within the community, Musqueam Health Services, which is based in the community, and they've been a key partner for us. And then, university-based researchers such as myself and students and so on. Our team over the years, of course, has been fluid and has included a whole host of different people over the years. Today, our team is quite large. We have a number of research projects underway. So we have many elders still involved, and we have community research assistants. Denise is one of them, and many others involved. And our approach is very embedded in community-based participatory research. So this means, of course, research that's focused on building partnerships and trust first and foremost. And that's not always an easy thing to do. And we're continuing to work on that 10 years later. But certainly effective research for Musqueam that improves the well-being of the people there, it can't be designed by me sitting in my office in Edmonton. It has to be designed by the people that live there, that experience the community in that context and know the community. So they're the experts and on the issues that are affecting them. So therefore, building relationships with community members is our foundation, rather than a means to an end. It's everything for us. It allows us to have responsive research that's community-led. It allows us to have research that is for communities and benefits communities. So as that little bit of background, our purpose is to work together to improve the health and well-being for women and children and families within the community from strengths-based perspectives. The primary means that we've evolved to work is through what we call community advisory committees. We have one for each research project that we have in place, and we have regular meetings with these committees. It's an equal space where no one is greater than the other one, and we're all equals. And that's where we come together to make decisions about what we're going to do, about what the research will look like, how we're going to do it, where the data will be stored. All of those decisions are made in those committee meetings. And we prioritize time for that. It's really important. Sometimes life gets in the way and that causes bumps in the road. So we have to remember to stay grounded in that. And that's an ongoing thing for our group. From this perspective, over the years, we've developed a set of, I guess, core tenets of how we work together. And I'll just very briefly go over those. I could spend an hour talking about them, but our entire research framework is centered on relationships. So we need to trust one another if we're going to work well together. So we need to spend a lot of time working on relationships as a team. It's not always perfect. And it takes a lot of time. We need to nurture those relationships. Ceremony is really important to us, and it permeates all aspects of our research and our work. It's very crucial to, I think, grounding ourselves in the spirit and intent of our work and the commitment of that. I think in ceremony, our relationships become more. We connect our hearts rather than just our minds. And I think it opens up a space of ceremonial thinking that, where really anything is possible. So it's very important for us to always be grounded in ceremony. Humility is a very important tenet for us. So, I mean, for me personally, that often means unlearning a lot of the things I learned in the past and opening my mind up to learning new things, and that, the Western scientific way isn't the only way or necessarily the right way, and that there's many other ways of viewing the world. So, researchers are used to being the experts, and, having a humility approach erases that. It makes space to acknowledge and explore and reconcile that we all come from different backgrounds and different systems of learning, different ways of knowing. So community-led for community benefit, I've talked about this already. That's what our research aspires to do, to be community-owned and to lead to benefits. So it's not just collecting information for the benefit of researchers or science or knowledge as a whole, but our goal is to benefit Musqueambies. We like to use a strengths-based approach. So our research is intentionally concentrating efforts on building upon community strengths that center on Indigenous ways of knowing. So rather than focusing on the deficits, which I think too much of Indigenous health research has done that, focusing on deficits and disparities, when there's so much strength, we can really flip that story around. Culturally based approaches have been a core tenet for us. So we've learned time and time again over the last 10 years that we must root our research in supporting healthy families in cultural revitalization, language revitalization. That's really important to every community member that we speak to. And quickly, community data sovereignty is very important. So we're very aware of the past harms that have resulted from mistrust in research and research that wasn't done in a good way. So we're constantly trying to situate the control within community members. To do all this takes a lot of flexibility and adaptability. It doesn't necessarily align with Western approaches to research and timelines. So we feel like we're always trying to reframe that. And, we need to go at the pace of the community. Our timelines don't always go as we might think they will, and we just have to trust in the process. Okay, very quickly, I just wanted to show our research group logo and the lay description of our research group that we worked with some Cree speakers from the community to come up with this. I think it's interesting to note that it's fairly similar to the knowledge mobilization image that Allison showed in her opening remarks, but we spent a lot of time in our community advisory committees, committee meetings coming up with this logo that we think really represents our group well and this description. Okay, so we've done a ton of work over the last 10 years. We've created an elder's wisdom video for parents. We implemented a prenatal gardening program. We had experiential learning opportunities for healthcare providers. We've done work on diabetes and non-communicable diseases. I can't talk about all of that. I don't have time. I just want to spend the next couple of minutes very quickly highlighting our current key projects that we have. So the first is our Cookum and Wissam support program. And really the purpose, and this was a community-derived idea, is to have elders in the clinical setting to support pregnant moms and their partners when they go through that very important time in their lives. So, the elders are there to support moms in any way they might need, really meeting them where they're at. It could be cultural support or spiritual support, emotional support, just someone that's been there, done that. We feel it creates a safer environment for them when they walk through that door into the clinic. And our early research has shown that, our program's providing multi-layered support and enhancing the cultural safety of the clinic sites. We had to really switch gears during the pandemic and move to an online version. And now we have a hybrid version, so in-person and online, where elders are connecting to parents. We're currently doing ongoing research of the impact of our program and thinking about the future, about how we might include aunties or birth workers to work alongside the elders, and really thinking about how can we sustain this program beyond the life cycle of research dollars. So alongside our Cookum and Wissam support program, we have what we call Deadly Dads, which is a men's support program. So we heard loud and clear at the start of our partnership that if we're going to talk about pregnancy, we have to include the men, as they're often left out. And we know that men play a very important role in the health trajectory of children. And we did some early photo voice work showing that, men in the community are wanting to reclaim their roles. And we see pregnancy as an opportunity to help support that change in a positive way. So we implemented our Deadly Dad support program to provide support for men in the community to, create a place for them to connect peer to peer, to do on the land training and learning, to play sports together, just to come together in a healthy way, to open up to one another. So we've had really good success with this program. It's ongoing. We're currently evaluating the impacts of our efforts over the last year or so, and there have been many efforts. And again, really thinking about how can we sustain this program. This is what keeps me up at night the most and I think a lot of people would on this call can probably relate to that. When we design these great programs that are derived from the community, how can we sustain them so that they live into the future? Okay, very quickly before I turn it over to Denise, the last key project we have is the one that Denise is spending a lot of her time on, which is what we call Indigenous component of the Healthy Life Trajectories Initiative. This is CIHR funded. Maskwacis is just one of a number of communities that are involved. And really the goal is to develop a national Indigenous driven cohort study where we have community derived strategies to support pregnant moms and their families. And then we're following those moms and families over time. We've been working on this for years. We've done a lot of initial steps within the community, like reviewing perinatal outcomes, doing interviews with leaders. We did a literature review and a community asset mapping exercise to see where the assets are in the community visually. We're currently collecting data from moms and dads within the community. So we have a survey and some qualitative data right now. Really, all of this work is to prepare the community and our team for the cohort if we're able to get the funding and implement this in the next year, and really refine our strategies, what those are going to look like. So what we've landed on is a one-stop shop kind of community guide model. So it's really a kind of a patient navigator system to connect moms and dads to the supports they need. So we hope to implement that soon and recruit participants. So that's a very, very quick overview of our research group. I want to turn it over to Denise to add her perspective and comments.
Hi, Mayo Geksepayao. Good morning, everyone. Denise Yang Nitsikasan, Niaskuyak Maskwacis Chinia. I'm from Treaty 6 territory. I'm from the Ermineskin Cree Nation. I'm an Ermineskin Cree Nation member. So Ermineskin is one of the 4 bands that make up Maskwacis. So there's Ermineskin, there's Samson, there's the Louisville Reserve, and then there's Montana. So our research includes all of the 4 nations. And one of the things that we found throughout our research was that there's a lot of programming in the community, but there's a lot of also disconnect and interagency and networking. And we don't want to replace what's already there. We want to work with what's there. And so our community guide that we're working on is looking to bridge those programs into like a brochure, a booklet for community members to use. It's going to be really geared towards like families for prenatal health. And also one of the really great things that we found as well was that women really feel like they're just lacking connection. And one of the strengths that we like to build upon with the Elders Mentoring Program is that cultural connection, that kinship that's happening at the PCN with the Gukums. And so we thought like, well, why not an aunties program? That'll help like give them that mentorship, help them mediate the programs in the community, help them connect to people that and the resources that they need. So one of the things we started doing was reaching out to midwives, Indigenous midwives. So we have 2 midwives. They started a Facebook page called Midwives from Maskwacis. And so it's really exciting because they're starting to make those connections with other programs in the community. And this is a really exciting part because this is where like the on the ground work change starts to happen, because once they already do have a mom that's interested in having a home birth. So I mean, that's just amazing, because like how amazing would that be to say that we're going to have our first at-home birth in Maskwacis and who knows how long. And so they're working alongside like our early years program at Maskwacis Health Services. They're doing a lot of great work, and they're working with other birth workers in our community. So it's really beautiful to see it all come together, really for just the needs of moms and women in the community, because this is what they're telling us through the research. So it's really guided, like the research and the strategies that we use are really guided by what they're telling us. So that's about all I have to say about that. Yeah, I hope I didn't miss anything, but I'm just kind of building off of Richard's slides. And we're looking to invite more CAC members from our community. So that's another step. So.
Wonderful. Thank you both so much, Richard and Denise, for a great presentation. And I know we already have one question in the chat, and welcome everyone on the line to continue adding in your questions, and we'll certainly revisit to learn more about your experiences. So thank you so much for such great presentations. I now have the pleasure of introducing Laurie Smith, who is the Program Manager of the Global Control of HPV-related Diseases and Cancer Research Program at the Women's Health Research Institute at BC Women's Hospital. Laurie, I'm very happy to pass the microphone over to you.
Thanks, Allison. And yes, our program name is a bit of a mouthful, isn't it? Just share my screen here. Can everyone see that? Okay. Thank you, everyone. I'm very honored to be presenting today and gratefully acknowledge that I am presenting from the unceded and ancestral territory of the Musqueam, Squamish, and Tsleil-Waututh Nations. I am the research manager of the Global Control of HPV-related Diseases Research Program, and we focus a lot on primary and secondary prevention of cervical cancer. I'm not going to go into a bunch of background given our time constraints, but do want to give you a little bit of context for the project that I'll be explaining a bit. So globally, those who do not receive cervix screening are the ones at highest risk of cervical cancer and precancer. And even in places such as Canada and BC, where screening is publicly available, many populations have challenges accessing or otherwise cannot attend screening for various reasons. And some of these groups include Indigenous people, those who live in rural, remote locations, immigrants, trans and non-binary people, those with a history of trauma. It's actually quite a long list. This is just a few. So to address these disparities in screening, we need to think of new and innovative and very inclusive approaches that can consider these various contextual, cultural, and other factors. And HPV testing has been shown to be highly effective at identifying precancer and cervical cancer earlier and better than the PAP. And not only is it a better screen, it actually has the opportunity to provide us with these innovative approaches that might actually be the key to improving uptake. So what a lot of people may not realize is that cervical cancer is almost entirely preventable through vaccination and screening. Yet, even so, there still remains a global burden of cervical cancer. And as a result, in 2020, the WHO adopted a global strategy for cervical cancer elimination. And most of our work these days in our team is really rooted in the global health or the WHO strategy. And these three pillars are improving vaccination, screening, and access to treatment for those who need it. I'm going to focus on the middle pillar there about improving access to screening with a HPV-based screening. So just quickly to give you an idea, with the pap smear, with cervical cancer, or with the conventional approach, women need to go to a provider. They need to go to a clinic, have a speculum exam where the clinician takes a sample of cells from the cervix. With HPV-based self-collection, that provider and speculum exam requirement is all, we don't need that anymore. The person can collect the sample themselves in the privacy of their own home or wherever they feel comfortable collecting. Only a small swab is required to collect the cells vaginally. So it's safe, easy, and painless, and it's actually very effective at cervical cancer screening. So we know that self-sampling is the intervention and it works, but how do we make it accessible, acceptable, and feasible to those who need it the most? So this is where we are getting into our experiences with community engagement and involvement in our self-collection work. And in the Fraser Health Authority here in British Columbia, they have some of the lowest screening uptake rates in BC in South Asian communities. So we have partnered with some South Asian communities to try to implement HPV self-collection there. In our work, we have used community engagement with our projects for years, recognizing that we can't do our research without it, and the needs of the community can't be addressed without it. So our first steps are always to approach the community with authenticity, with respect, and a commitment to learning and honoring their values and learning about the community and what their needs are, what their priorities are, and emphasizing throughout the process that they truly are the partners and drivers of things. So these are these first stages of our projects. And they always start with a conversation, and these conversations start early. And what I mean by early is sometimes even before you've got your grant funding, even before you've applied for a grant and you've designed your implementation and how it will roll out. Because if we don't start those conversations early, we make assumptions, and I think it's very important not to do that. So starting this early and taking this time to learn the values, learn about the community, their culture, etc., it takes a lot of time. And this is sometimes a luxury I think we don't have in research, but we can't emphasize enough the importance of this time investment in this stage. And it does take time to build trust. And it does take time to learn if our research question is a priority in the community. We always find it very useful and actually critical to involve a community champion. And here you see our community champion for this project, Dr. Nazia Niazi. She is a force in the community. She's a fierce advocate of women's health, and she has the great respect and trust of her community, and she also actually trusts us as a team. And so she was that bridge to getting us introduced to various people in the community, helping us to learn what the priorities of her patient population and her community members were. Without her, I feel like we wouldn't have had that bridge, and her involvement was a key piece of our project planning. And this involvement with the community it's an ongoing, evolving, iterative process. And we say community involvement, they really aren't just involved. They really determined how screening would be implemented. They were the drivers of how it would be rolled out. Would we offer self-collection in clinics? Would we offer it at community centers? Would we mail clinic or kits to women's homes? These were the kinds of things that the community helped us determine would be feasible. When they are involved in helping us design the process or determine the next steps, they're invested and they feel they have a key role in determining the implementation process. Sort of one thing we always like to plan in the beginning is also the project when it's coming to an end. We're still, this project is still ongoing, but in these early days, I think it's important to talk about sustainability. And, we're offering an intervention that isn't part of this provincial screening program yet. So when we are finished our project and we can no longer offer self-collection, what can we do next? What can we do to help keep this momentum running, to keep women getting screened that maybe wouldn't have otherwise received screening before? These are really important things to talk about in the early days and help us plan for those stages. Another important thing that we do in the early days is involving the community in a knowledge translation plan. So at the end of a project, there's always lots of peer-reviewed publications, etc. But how does the community want to hear how this project unfolded? And we hear time and time again from participants in our work that they want to hear how the study ends, what were the findings. So involving them in that plan. Is it going to be a community event? Is it going to be a webinar, newsletters? We need to hear from the people that were involved in the project to help us determine that. So I think a few considerations that we always like to have in our projects is to, again, I can't emphasize enough that time investment. It may not be something people realize how much time needs to be taken into those early days to establish that trust. And to know that the process isn't linear and to be prepared to be adaptable and to pivot. There are a couple of times in our projects where we might have started with one approach to offering kits and we had to change because of feedback from the community. Being prepared for changes to the community is also important, and we've learned from our work that let's say a community champion or a leader changes, how can we keep the momentum running and the relationship established as these changes to the community occur. There's also external factors. Perhaps a global pandemic might come along and affect your research. So how do you adapt during those types of things? And I think another very important piece for all of our work is that we request feedback all throughout the process, not just at the end, requesting that feedback from various players and stakeholders within your community, and be open to any kind of feedback you get. Some of our successes are with this approach is that with this level of involvement with our communities, there is empowerment of the community. And we can build trusting and ongoing relationships because of our experience with Dr. Niazi. We've actually been able to work on several projects with her because we established that trust and rapport with the groups and the communities, and they gained their trust in us. And involvement in the community, I think this is boldest one is it ensures development of interventions that may actually work in the real world. We weren't sitting in our offices assuming what might work in this population. We used the people in this community to help us design the intervention. And ultimately, this is helping us improve access to cervical screening in this population. So I thank you, and I look forward to questions in the next session, but I'm now going to stop sharing. And I'm going to introduce you to our colleague in Uganda, Dr. Caroline Nagasiti. She is leading these projects in Uganda for us, and she is joining us via a pre-recorded session due to the time difference in Uganda. And the quality is a little bit poor, so we've added some subtitles so that you can better catch what she's saying. I'll hand it over to Dr. Carol.
Hello, everyone. It's an honor to be on this platform. My name is Caroline Nagasiti. I am a gynecologist at Uganda Cancer Institute with a bias in cervical cancer prevention. Thank you.
Thank you so much, Dr. Carol. The first question is, how did the knowledge and perspectives of community health workers, who are community members, influence the design of cervical cancer screening implementation research in Uganda?
Thank you. Community health workers are usually not well schooled, or they haven't gone far in school, but these are influential leaders in the community who are responsible for the health of the community. They may not be so well educated, but they are very important people. You can't do much in the community without them. So when we first interacted with them, had no clue what cervical cancer was, and they didn't know what we were talking about. But then we had a training with them, we shared views. So then they realized they actually had a problem in the community. The women were there who had symptoms we were talking of, and before they thought it was witchcraft, and there was nothing one could do about it. So once they learned to something that could be prevented, they wanted to be drivers in preventing this. They wanted to be involved in everything. So we trained them, and they literally drove this study right from creating awareness, educating the community, getting the women screened, ensure they are treated. They literally did everything. Once they acquired the knowledge, they just transform everything. Thank you.
Thank you so much. Did insights from community women improve the availability and acceptability of cervical cancer screening, of how cervical cancer screening was offered, and contribute to cervical cancer screening uptake among women in these communities?
Yes, indeed. When we got to the community, prior to the actual study, we had a pilot. It was a kind of qualitative research. We wanted to know where to start from, what they knew, what they preferred. So in this pilot, they were strongly geared towards the fact that they could screen themselves. That was something that was very strange. Because one of the things that kept them away from the facilities was the facilities were far, and that the facilities were far, and they felt they had no privacy. I mean, having to bear themselves before a stranger, that's something that they didn't like. So when they could do it by themselves in the confines of their homes, that is something that they grasped. Initially, with the health workers kept saying, no, they couldn't do this by themselves. It's possible. They would not accept it. We were surprised. They embraced it and they said they were ready to do it because it was comfortable for them. It was convenient. It didn't cost them anything. It just, the service found them in their home, and that geared the design of the study.
Thank you. And I think you've spoken to this a little bit, but what strategies were employed to mobilize broader community support for cervical cancer screening and create an enabling environment for women to participate in the implementation research?
Thank you. Prior to implementation itself, we had a stakeholders meeting where we sat with the community leaders and we told them what it is that we wanted to do. They embraced it because this is something that was eating them up and they had no clue it could be prevented. So right from the leaders were able to disseminate the information down to the grassroots, telling them this is something that each of you needed to get involved in to save their women from dying. We also had meetings with the men because we knew that men have a big role to play in the lives of the women, and the men also embraced it. Actually, one of the problems we had with men is after they learned how it is passed on, they kept saying, so what are you going to do for us? If we're the ones making our women sick, what should we do? And we are like, support them. If they need treatment, please facilitate them and stuff like that. So the whole community embraced it. This was something new, and they were happy that they could do something for themselves to keep themselves going. And then the other thing was that the fact that the entire thing was being manned by the community itself. The VHTs were driving it. The women were screening themselves. It was something that worked so well because the community felt empowered to do something. For the first time, they could do something to drive their health in a positive direction.
Thank you. My final question: has involvement of community members during the design and implementation of the research had any effect on the sustainability of the cervical cancer screening and treatment program in the community?
Sure. And we are happy that we were part of this. We have just finished drafting our strategic plan. the cervical cancer prevention and control strategic plan. It had long expired in 2014, so we have just finished drafting it. And for the first time, we were able to extend screening to the community. Previously, screening started from health center 3s and above, but we were able to show that it is possible to have the screening go down to the community. Because it hasn't worked. For a few years, we have been carrying out cervical cancer screening, but we sat in the facilities. We waited for the women to come to us, and they didn't come. So this time, when we showed them that it is important that we go to where the women are and actually works, it was embraced by the Minister of Health. So we included it in the strategic plan. So right now, screening starts in the home of the woman, right up to the highest level in the health system. So that is something we are happy we contributed to the plan. Then the other thing was, we used to think that only trained midwives and nurses could actually screen, and these are very few. It was such an overload to them because they are doing so many things, and we are saying, in addition, you have to screen the women. So screening was not high on their list, which kept the women waiting because the midwife is busy conducting the delivery. But now we are saying, no. The community health workers can help these women do it. And that has lifted the load off the midwives and the nurses, and the governments are happy, and they're like, okay, that is something that can work. So for the first time, the community health workers are actively involved in getting the women screened for cervical cancer, something we never thought could work. The most important thing was the follow-up. Follow-up has been such a big problem for us. Like I've said, in previous studies, it ranged from 6% to 16%. However hard you tried, the women were just not getting treated. Most importantly, we would carry out outreaches where we would screen the women and we expect them to come back for follow-up. They just didn't come back. But this time, with the involvement of the community health workers, our follow-up stepped up to more than 70%, and so we are happy.
So much, Lori, for your presentation and also facilitating the technology for Carolyn's really engaging sharing of experience in Uganda as well. So that brings us to the end of our presentations today, and really pleased that we have about half an hour left for a bit of a question and answer discussion with those of you joining us today. And we do have a few really great questions in the chat, as well as just to note for our speakers, some recognition of thanks for the inspiring presentations on community-centered research and the dedication of you and your research teams towards improving the health of communities and their well-being. So I will invite individuals to continue to enter their questions into the chat, but we will start with a question that came in from Elizabeth. And Richard and Denise, I believe that this one I will turn to you for, noting that in your presentation, you did mention the importance of community data sovereignty. And there was a question that came in related to data sharing and access in the community and the navigation of research ethics boards. And Elizabeth had shared her recent experience where there had been a question coming in from the REB related to concerns of confidentiality and privacy of data. So was wondering if you would be willing to share your experiences in navigating that data sharing and access experience with the community and any of the ethics requirements that accompany that.
I can share a little bit. So as we try to make clear, like every aspect of our research is in the hands of community members, including the data. So we have a living document that's evolved over the years. It's a research agreement with our community partners. And, it describes who owns the data. It's co-owned between everybody involved. So, and where it's stored, we've come to an agreement about that. And a big step for us to kind of get over some of these hurdles was ratifying, I guess, our research agreement through the U of A. So I'm not sure if other universities have a similar process, but we had to submit it and did some back and forth, and, you know, essentially got their approval. And now in all of our ethics applications for new projects or continuing projects, we include our research agreement. So it's all really upfront and clear how the data is owned, shared, and accessed. So, you know, our REB knows about how we do this early on, and we're very upfront about it. So because of that, I don't think we've encountered the problem that the questioner had mentioned.
Wonderful. Thank you so much, Richard, for sharing that experience. The next question that we have relates to the support. I guess it's really sort of housed within the context of the COVID-19 pandemic and the impact that that has had on all kinds of research, but very much including community-centered research. And there was a question that came in from Maria related to support for elders and noting the importance that they played in some of the research projects, Richard and Denise, that you spoke to. Wondered if you might be able to reflect on any support that was provided to them to in turn enable them to have sort of the, I guess, be able to still have the ability to support individuals in the community, recognizing that in the case of Maria, there had been just a really overwhelming feeling within the families that otherwise they would have engaged to support other families. So pleased to pass it over to you, Richard and Denise, and Lori, please feel welcome to put your hand up as well. Appreciating COVID really hasn't had an impact, I think, across many projects.
I can take a first stab, and then Denise can probably add a lot more than I could because she's like on the ground with the elders all the time. But I would just say that like it's been an extremely difficult challenge for everyone in our team, right? The elders, but everyone. It's very emotional work. It's very draining work. It can be triggering. So we've done some things to try and mitigate some of that, like a series of trauma training for our team and some team sharing circles and coming together in that way. Pre-pandemic, we would sort these things out, I think, by supporting each other face-to-face on a regular basis in our meetings. So not having that connection for 2 years has been really hard on the elders and us. I think it's eaten away at some of our trust too. And it's eaten away at a chance to be together for a couple of hours talking about these sorts of issues and supporting one another. So we're only now getting back to doing that. We had like one of our first in-person community advisory committee meetings for one of our projects last week, and it went really well and people felt that connection. So we don't underestimate the importance of that. And the pandemic is just, I think it's showing itself in so many different ways and so many different cracks. It's not easy, but I'll turn it over to Denise to maybe provide a bit more if she wants to.
Sure. So yeah, that definitely, like, even as a community member doing interviews myself, like I found I was triggered at times to provide that emotional support through interviews. But one of the things we did for our elders was to engage them in training, trauma training and information. So they really appreciated that. Actually, one of our elders got COVID when she was there. So that was a bit of, so they missed a bit of that. But we're looking to like have them finish the workshop that they started. So, but it's really just checking on them a lot and seeing what they need. Like a part of like my role as a community research assistant is to just be there for them and give them that extra support, or just if they need anything to let them know that we're there for them. And I think that's really important because it makes them feel appreciated, and it's always sharing, being transparency and sharing what we learned through our research, because once they get that feedback of how important the work is and what they're doing, like it drives them. And and it makes it that much more meaningful for them. And they lean on each other. So that's really important, to give them that space to like talk to each other, and just engage in conversation. Yeah.
Thank you both so much for your insights. Definitely a challenge. It's really appreciated to hear your thoughts on the realities of that and some things that worked in your context. Lori, I just wanted to do a check with you and see if there was anything that you'd like to add. I know a different type of research team and focus, but I appreciate that the pandemic likely had an impact on how you engage. So just wanted to do a check and see if there's anything you wanted to add.
Yeah, thanks, Allison. And yes, I think we'd all agree that the pandemic affected every element of everyone's life. And in the Fraser region here in BC, it was particularly hard hit during the pandemic with very high pockets of prevalence of COVID. So I think, again, this is where I go back to just being adaptable and listening to the community needs and recognizing that these kinds of experiences are times where the research may not come first, obviously. And so just being very open to listening to what the community needs were at that time. It was a time where the healthcare providers who we were partnering very closely with had other priorities. And so we really had to pull back and allow the community to heal and do what they needed to do in that acute phase, and then listen to when they were ready to start picking up the project again. At the same time, just with the nature of self-collection, it also provided us an opportunity to think of a different way to offer screening to people who weren't, outside of our project across BC, who weren't being able to be screened because of the pandemic. So it helped us learn how offering self-collection and a new, approach to screening could still reach women in many ways who were now affected by the pandemic. So it was a learning process for all of us. And again, just pivoting and adapting processes once providers started seeing patients and that kind of thing. So I think, and just to, Denise and Richard's points about just the emotional impact, it was really important to take that into consideration as well. What was the bandwidth of people and the experience of the communities in the Fraser region.
Great. Thanks so much, Lori, for adding those reflections. And I'll actually come right back to you because we have a new question in chat from Elizabeth that was asking for your reflections on navigating treatment access. So happy to pass that question right back to you and welcome your reflections.
Thanks, Elizabeth. That is a fantastic question, and I really didn't touch on that in my presentation. We always say in our team that improving access to screening is one thing, but if we are identifying women at risk of having pre-cancer or cancer that need further follow-up and they're not getting that follow-up, then we're not doing our job by improving access to screening. So our whole cascade of care in our project plans is to make sure that those who have an infection detected or cells found that need to have treatment get access to that treatment. So I can speak a little bit to both projects. I won't speak for Dr. Carroll, but I can provide some of my knowledge of the experience in Uganda, is that the community health workers would personally provide the results to the women that had HPV positive results. So they would go door to door or at community events, bring them into a private space and discuss their results with them and then offer them the next step. So we tried also to bring treatment closer to the community so that women did not have to travel far. In Uganda, a lot of that treatment is a geography or access issue, and training nurses and offering a treatment approach where they could have the treatment at the same time as it was often a two-step process prior to our project. And so we tried to allow women only one visit or offer them only one visit where they could get the treatment at the same time. Again, a lot of that support from the community health worker, I think, was very important. And as Dr. Carroll said, that most women attended their treatment as recommended. And I think it really was large in part due to the involvement of the community health workers and their involvement from the whole process of sample collection moving forward. With our work here in BC in the South Asian population, part of the reason why people don't access screening is maybe lack of knowledge of the need for it, having a male provider. And so offering self-collection, it removed some of the cultural barriers that we've experienced with access to a male provider. But then when people have to go for treatment, they still have to go to a provider for a speculative exam for the next step. So that is a challenge that we have to recognize. And so listening to what the community needed to facilitate that, having a navigator with that patient, a support person, someone else they trusted, either explaining the process to them or with them when they went for their appointment, explaining the importance of this next stage of diagnostics and or treatment. So it was really a multi-step, but asking the community to help us determine what was needed to convey the importance of that to women. I hope that answers the question, but again, thanks Elizabeth for that.
That's great. Thanks so much, Lori, for your thoughtful answer. And so I believe that we have made it through the questions in the chat. So I will follow up with my own question to the panel members, but I just wanted to note that we do still have a little bit of time. So if there's anything that participants have been wondering about, please don't hesitate to add it into the chat and we will make time to get to it. But in the meantime, I will welcome reflections from Richard, Denise, and Lori related to your experience with mobilizing support to the broader community in terms of improving women's health through the research process. Would invite your sort of overall reflections on what you felt were your successes, your lessons or your challenges, and any lessons learned that you've taken out from the projects that you shared or the established networks of communities that you're engaging. So would welcome, maybe I'll turn Richard and Denise, turn to you first, and then Lori will come to you for, again, reflections on successes, challenges, and lessons learned.
Do you want to start, Denise? I feel like I keep stealing that.
No, that's okay, because this is one I have to actually think about a little bit if you want to answer first.
Oh, yeah. Like, I think we, as a team, think about success perhaps differently than many research teams might from a Western paradigm. Like for us, if we have an ongoing relationship and collaboration and partnership, that's a success for us. If we've developed like good ways to work together. So it's not necessarily about research outputs and things like that. So that's always front in mind. So I think, Denise being here today and being a part of our team is an example, for me is a success. Like someone from the community that's a full-time research assistant that is leading a lot of the work that we're doing. Like we're really trying to make this community owned and community led. So that's just one example. Denise is one of our research assistants, and just the contribution of community members and their leadership and their commitment to our work, I think, is a success. I hope I'm answering the question. Challenges, it's always, for me, it's time. Like we write into our grants prioritizing time, and we've been really lucky in getting funding from funders that understand that. But for me personally, just having to juggle so many things, I wish I had the time I used to 10 years ago when I was going out to the community to just sit and visit with people. So that's proven to be a real challenge, especially since COVID. And it's not over, but it's a new world now. Like we're expected to be on Zoom all the time, right? From our home offices with meeting after meeting after meeting. And it was a different world before. I I didn't even have Zoom before the pandemic, and I had more time. And I think a lot of us had more time. So for our team, I have to reclaim that time somehow.
Thanks so much, Richard. I think that probably resonates with many on the call about the challenge of time and the need to rethink about how our days are spent. Before going to Lori, Denise, just wanted to turn to you. No pressure. Just wanted to welcome if there was any reflections you'd like to add to this question.
Yeah, I think one of the challenges, like, and just working as a community research assistant, is knowing the dynamics of working in First Nations communities. And I think Maskwacis is a little unique in the sense that, you know, we have 4 communities side by side. So that does present a bit more of a challenge when we're coming together to plan events, research, everything really. Because one of our goals long term, like that just came to be recently, is like the possibility of maybe one day having a birthing center. But even that it can't be just a one community birthing, like it has to be 4 nations. So that's the challenge, I think, for me, that kind of sits in the back of my mind constantly. And then engaging all those interagencies, it's tough work. And it takes a lot of time. So it, like, on top of not having enough time, it slows down a lot of the progress that we need to make, but it's vital to our sustainability long term. So that's kind of the one challenge that keeps coming up for me anyways. Lessons learned is that I forget how much I'm affected by all of this. And so I have to remind myself to be grounded sometimes. So yeah, that's all I have to share.
Thanks, Denise. Those are all really thoughtful. Appreciate you sharing. Lori, we'll turn to you and see if you'd like to add anything in terms of successes, challenges, or lessons learned, anything that you haven't spoken to yet.
Yeah, I think a challenge challenge mobilizing community support is maybe knowing who in the community, you know, we went in with knowledge we wanted to get women screened, but who in the community maybe that we didn't already have conversations with, did we need to have conversations with? So, and is improving access to screening a priority for the community? So I know I spoke a little bit about that, but really understanding what the priorities were in the community, I think, is very important. If you don't know that is going to be challenging. I just echo what both Richard and Denise said, which is why I emphasize so much about that time investment. When it can be a luxury, but time really is important to establish bonds and relationships and trust. So I think time can be a challenge. A success, when you involve the community, and I said this in my presentation, but you're really determining and developing interventions that work in a real world scenario. And so that to me is one of the most valuable things, is when we involve the community, they're designing they're designing the implementation of it, and that is something that could work in the real world. And then we can take those successes and these findings to programmers, policymakers, that kind of thing. Our job is then to convey these findings to the BC Cervical Cancer Screening Program, and they can probably find value in how we engage these communities. And lessons, a lesson learned is I go back to what Richard said about humility, and I think that's incredibly important, is to just recognize, to have that, possess that, and maybe redefine success sometimes. I think that's an important lesson learned, is we might at the beginning have an idea of what our successes might look like, what are the metrics, but be open to reevaluating success, and maybe the community, involve them in what their definition of success would be as well.
That's great. Thanks so much, Lori. And just being conscious that I did miss one question in the chat. And this is the first one that came in from Tennille. And I think it actually ties in very nicely with the reflections on the challenge of time, as well as flexibility. So Tennille had just posed the question that with taking community-centered approaches, that there is really a need to be flexible and adapt, and appreciate that can extend timelines. So it was a question that I'd welcome to the three of you in terms of that element of needing to adjust approaches, adjust timelines. Has that come up for you as a challenge with funders or groups that are supporting the research that you're conducting? And if yes, if there's been any strategies that you've undertaken to sort of seek a shared understanding of what that means in terms of needing to keep a flexible approach to accommodate really having meaningful engagement and having the research being driven by the needs of the community. So welcome, maybe Lori, I could start with you, and please feel welcome to pass if it's a question that you don't feel comfortable or posed to answer, but just welcome your thoughts to start.
Yeah, no, yeah, we definitely have had some challenges with the timeline. So I think I'm just thinking of an example. We've had funders come back to us sometimes asking in our project plan, why do you need so long in this first year of infrastructure development? And so to be able to go back to them, and maybe this is where it's going to take time to inform and for funders to adapt to how long it might take to develop these relationships and to involve the community. So it will extend timelines for projects, but in the long run, it's a worthwhile investment. So yeah, and I guess just these, and another example is when we have, again, developed a protocol and a process, but then we, early on realized that maybe we did need to shift that, because even with the community's involvement in our working together, we realized that approach needed some tweaking. So I think just being able to be adaptable where possible, and we did have the luxury of doing that. I know if in some projects it might not be that feasible, but perhaps that's part of a plan for these contingencies, is if we do have to pivot, then what does that look like, and how will that affect the timeline, or many other considerations. But also, particularly with our work in global health, I think we've always learn to expect the unexpected, and so being adaptable is something I think as a researcher that it comes as part and parcel and part of the territory.
Thanks so much, Lori. Richard and Denise, just turning it over to you to see if there's anything you wanted to add based on experiences with funders or others supporting your project, and how you've navigated those conversations when flexibility or more time's been needed.
Yeah, I think our conversations today and what Lori just said really shows how there's obviously a need to be adaptable and flexible. I think in the past, we had some challenges with funders in that regard, but not of late, because I think when we write our grant proposals now, like, we're very clear in describing that you can't prescribe the amount of time it would take to build relationships or engage the community or go at the pace of the community. And we talk a lot about in our grant proposals about that and how we work with the community. So it's very clear to the funders, and they've, funded us. So they're well aware that this is the path that we're going to go down. So they've been supportive. So I think being clear about that and writing your grant proposals is important.
Thanks so much, Richard. And as a funder, I think I could say that I think that we're also hopefully increasing our learning on the importance of the approaches and really taking, just the need to allow for that flexibility with research that's done by communities, because we do really want to encourage that approach. So I believe we will now turn to the last question before wrapping it up today. And I know this is a topic that, again, we have touched on a little bit. So, okay, if you wanted to pass, but did want to ensure that we had a little bit of space to speak about sustainability. I know it was something that came up, some of the groups, the importance of having community groups that, Richard, for example, I know you spoke to having an established community connections, but with different projects that would kind of come into play. But also appreciate that sustainability was also mentioned as a challenge in some spaces where a program's established, it's really successful, and then what next? Lori, I believe it was you that also spoke about the need to plan right up front about the what next. So just wanted to, again, just create a little bit of space to hear from you if you have any thoughts, particularly about through the engagements that you've had with the community, how that has influenced the sustainability of the policies or the programs that you're using, and wanted to welcome your reflections on generally thoughts around sustainability, any challenges, any tips, any things that are working well. So this, I think, will be our last question for today. So also welcome, if there's anything that you haven't shared as a reflection that we didn't get to, please feel welcome to throw it into your response. So Lori, we'll go with you, and then Denise and Richard will turn to you.
I did mention some of this, so I'm not sure how much more I have to add to it, but I think that our learnings from our project is that we have been able to take to the screening program here in BC. In addition, our findings from our work has really also been, we're starting to hear from the Canadian Partnership Against Cancer and work with other groups across Canada. So I think maybe just our definition of sustainability as well might have to be a little more open with this, because yes, at the end of our project, we may not necessarily be able to continue to offer self-collection to people of this community. However, perhaps down the road, we can, that the findings that we've learned, we can then take to decision makers, and that can be part of the process there. Maybe another little aspect of sustainability is that for the people of the community themselves is that they've seen they can trust some of the providers, they can trust the process of screening, and maybe although our specific intervention may not be able to be part of the community, there's components of the whole process that can be sustainable within the community, and the process for screening that I think that the community is going to adapt or adopt. But other than I think what I've said before, I think those are maybe just a few more reflections on that.
Thanks so much, Lori. Denise and Richard, happy to give the last word to you before we pass back to Tennille to wrap us up for today.
Do you want me to start?
With no pressure, and you're not a problem if you feel like you've already covered this question well. That's just fine too.
Yeah, well, like I said, it was one of the challenges for us. It still is. We continue to add it to our community advisory committees because we need to continue talking about it. The thing again is, like, Musqueam is 4 nations, so it's really key involving all 4 nations of Musqueam when it comes to sustainability. The really great thing is that we have a new research associate that's a little bit more experienced, I guess, or has a history of knowing how to navigate creating sustainability with programs. So she's brought up in our previous CAC meetings the idea of like having a not-for-profit organization to kind of drive, because once the research is done, right, like we don't want to see the elders mentoring program or the Deadly Dads group, like it's so vital to keep these in the community, but the community needs to take over, and it's just, how does that happen? So it's a constant question, it's a constant discussion, And again, I think it just really focuses on how important that interagency network is, and including them through the process. So we were just talking about this yesterday at a meeting with one of the new research assistants, and talking about how it's going to take, it's not going to happen overnight. It's not going to happen in 5 years. Like, it could take years until we get there, but we want to make sure we're doing it the right way. That's accountable to the community.
Thanks so much, Denise. Wonderful. So thank you so much to all the panelists for such thoughtful, just very open sharing today. I certainly learned a lot, really appreciated hearing your presentations as well as your responses to the questions. So thank you for being such a pleasure to collaborate with the panel. And Tamil, thanks again for the invitation on behalf of all of us, and happy to pass it over to you.
Thank you so much, Allison, for your presentation and your wonderful moderation, as well as to Richard, Lori, and Denise for your very thoughtful interventions, and to all of you who chose to attend this session. I think for me, some of the things that I'm taking away are around the experience that is necessary. And I think you gave some really practical tips to people about really asking for what you want and need to be able to do this community engaged and involved research, and building in the time to build the trust and to have the ability and flexibility to pivot. And also, I just want to underline how you all demonstrated that doing so really creates programs and can create policy interventions that work for communities and transform relationships, not only with researchers, but with service providers, and can start a pathway towards community ownership of those programs that have worked for them and that they want and are priorities. So really exciting. And I'm really thankful to you for sharing these lessons learned about how community engagement can contribute to mobilizing knowledge for the benefit of women, children, families. So I also want to flag for you all that and welcome you to consider attending our next seminar, which will focus on researchers working with service providers in order to mobilize knowledge inside of the health system and to transform practice. And that will take place on November 23rd at the same time across the country. So starting at 9 a.m. In BC, 10 o'clock in Alberta, noon in the center time zone, and at 1 o'clock in Atlantic. And our speakers will be Dr. Janice Dumont of the Women's College Research Institute and Dr. Natalie Rosen from Dalhousie University. So thank you all so much again for your engagement and participation, and we'll look forward to meeting up with you in a few more months to continue this discussion. Thank you.
Thank you.